All right, welcome everyone to our first implementation science seminar / webinar. And the focus of this seminar is to introduce faculty as well as graduate students into different models of implementation science. Particularly, we want to focus on evidence-based research in public health, translating that and presenting that to you, specifically in low and middle income settings. And today, we have an awesome guest speaker, Dr. Gbenga Ogedegbe. He's a hypertension researcher as well as an implementation science expert, and he'll be telling us about his global health work around implementation science. And this is going to be a monthly series, so each month we're going to have a new guest speaker talking about that. After the session, you have time to network. For our listeners who are out there, you can send in questions through the chat box, and our presenter will be able to answer that. So without further ado, Dr. Gbenga Ogedegbe.
Thank you. So I'm excited. Before I proceed, I should probably say Happy Women's Day. Otherwise, my wife would kill me if I don't do that. I think today is March 8th, if I'm not mistaken. So, it's a big day. And so the title of my talk today will be Path Shifting Strategy for Hypertension Control in Ghana. So what is implementation science? Let's start with that first. The little clip I have here just shows the way I define implementation science.
Think about it. If we do something that works, and there is only one, there is no guarantee that the same thing will work in a different place. And there is no guarantee that it will work again in a different population. So with implementation science, we get to fully understand the process, and we get to fully develop and appreciate the challenges that we need to overcome to scale this up. So the importance is crucial. But if we miss this, we're going to be spending a ton of money on a strategy that may not work in other populations. So implementation science is a way for us to really arrive at a robust strategy that can be cost-effective in the long term.
So that's the spiel I gave at the Global Alliance for Chronic Disease in November of last year in Argentina. So I'm part of this network. The GTD Network is really looking to fund programs that will advance implementation of evidence-based strategies for the management of non-communicable diseases. So I'm part of that network, and we're all asked to give our own definition of what NCD actually means. So what I've done there is give you really a very, very brief snapshot of what that means. So let's shift gears and look at implementation science from the perspective of a particular disease, because it's important that we understand it with diseases. I'd like to talk about what we know in terms of cardiovascular disease, because I'm a primary care doc, I'm an internist, but I also happen to be a hypertension specialist. We run the hypertension program at Bellevue Hospital with my group one day a week. So if you look at the burden of high blood pressure in sub-Saharan Africa today, you will see that most of the issue that is driving the uncontrolled hypertension that we're seeing is largely due to poor access to care, the acute shortage of healthcare providers, and really the high out-of-pocket costs due to lack of insurance. So if you really think about it, sub-Saharan Africa actually bears about 24% of the global burden of disease in terms of non-communicable disease, right? But they only have 3% of the global health workforce. Let me give you some numbers. So if the WHO is saying that we need at least one physician to about 5,000 population, in sub-Saharan Africa is about 1 to 50,000. A country like Nigeria is 180 million people. Actually is doing well. It's about 1 to about 5,500. Country like Ghana is about 1 to 12,000. Tanzania is a bit of a problem. 50 million people thereabouts. Looking at about 1 to 20,000 thereabouts. So in other words, there's an acute shortage of healthcare workers. So with the rising burden of hypertension, the question becomes, what do we do about that? So here are the major barriers, right? We just talked about the acute shortage of physicians. You can't have physicians everywhere. Ghana has probably about, I want to say, let's say 3,000 doctors. I'm being very generous. We have 3 major towns in Ghana: Accra, Kumasi, Takoradi. The big problem is that most of those docs are actually in those major areas. So the rural areas just don't have the physicians. So if we have to train enough doctors to spread across the continent, we just won't have the bandwidth to do that. The second issue is that the health-seeking behavior among Africans is largely driven by acute care. And because it's driven by acute care, most people will not show up until they're really sick. And when they do show up when they're really sick, they tend to pay a lot of money for admission and for their treatment. So the idea that we can think about prevention becomes a problem. And then finally, for access to care, the issue here is that we just don't have a robust healthcare system that can begin to even start to address some of the epidemics, talk less of the chronic disease that we have in the region. So the Abuja Convention was convened in 2008, I believe, in Abuja, Nigeria, where a lot of the African Association or African Union members, head of state, showed up. And there was a convention where they all agreed to actually say they would fund, part of their GDP would fund healthcare systems. At least 5% was committed, right, of the GDP. In the US, I think we're about 14 to 15% of our GDP. That's a big deal. That's a whopping amount of money. There, we're asking for 5%. Most countries, 0.1 to about 0.2%. Rwanda is doing a good job. Tanzania, I think, has stepped up a lot. I can't say what the number for Ghana is, but the point I want to make is that because of the lack of robust healthcare system, it makes it very difficult for folks to have access to care. And if you don't have access to care, if you have to pay a lot of money when you don't have access, if you don't have enough healthcare workers, I think it's a tsunami waiting to happen in terms of how we manage funding diseases. So in that regard, task shifting strategy has been taken as a way to start to think about addressing this problem. So for just academic purposes, task shifting really is how you shift or share duties from primary care providers to nurses. And it's a potentially low-cost strategy for mitigating systems-level barriers to hypertension control, particularly in low-income countries. Simply because it utilizes multiple strategies. And all of these strategies actually can be adopted for any given chronic disease. Let's just think about it. Screening for cardiovascular risk assessment, anybody can do that. You don't have to be a doc to do that kind of work. Basically, you're going to be asking questions about what is your age, do you smoke, are you male or female, do you have diabetes, do you have high blood pressure, do you have high cholesterol. And sometimes you can weigh people, and if you put that into an equation, you can get a better sense for how high they are risky. Counseling around lifestyle modification. Do you plan to lose weight? Do you plan to exercise? Do you plan to adhere to your medication? Do you plan to adopt a healthy diet? These are not things you need a specialist to be able to do. Initiating medication treatment. There's a bit of a concern that you don't want to have non-physicians prescribing medication, but we have a ton of evidence showing that with the HIV epidemic, we're able to do that, to task shift these duties to non-physician healthcare workers. And of course, can you refer people with complicated cases to a specialist? So the WHO actually adopted this in 2008 and came up with very specific guidelines on how to do this work. Here's what their package looks like, and the first package they looked at, and I'm not going to spend too much time, but if you want for reference sake, I put it here. The WHO has something called the CBD risk management package for low and medium resource settings. And the idea behind the package really is to figure out a way to integrate all of these tasks, right, into how a primary care non-physician can manage hypertension, using hypertension as really an entry point. And so before our study, what the WHO had done was actually implement this program in China and Nigeria with 40 practices. And this was, I think, around 2012, 2002. And what they found was that if you train nurses to deliver hypertension care, you actually can bring down blood pressure and it can improve control. What they did not do was integrate this program into an existing healthcare practice. So when we applied for a grant in 2012, we asked the primary question: can we implement, using implementation planning strategy, the WHO package in Ghana? Can we integrate that within the Ghana Health Services? That was our primary question. And we had to figure out, if we do that, was that going to be sustainable over time? So let me just share with you a few slides about task shifting so you can get a good sense of this. So you can task shift in one of four different categories. One can be your task shifting duty, right? From specialist physicians to non-physician clinicians, right? So that would be people like nurses, right? Or even advanced nurses. Or sometimes, depends on the country, they call them medical officers. These are people who actually, they're not physicians. Here we call them physician assistants. They can actually perform really somewhat skilled level of services. And then you can go from them to nurses, and you can also task shift from nurses to nursing assistants and community health workers. And this is where most of the work was done. Where if you look at people living with HIV and AIDS, if you look at the epidemic of the HIV in Sub-Saharan Africa, this is where a lot of the PEPFAR funds, that's the Presidential Task Force money on HIV prevention and treatment, that's where that money was spent for the most part. Without this kind of task shifting, I just don't see how we can have a better sense of how to mitigate it. So there are different ways to look at it: physicians to non-physician, clinicians to nurses, and then to nursing assistants as well. What is the evidence that task shifting strategies are effective in reducing cardiovascular risk factors in low-income countries? So one of the things with implementation science research is to make sure that whatever you're trying to propose or implement, it must have proven efficacy, proven effectiveness, and really, for the most part, it must have shown to be cost-effective. So if you don't have an evidence-based, guideline-based strategy, you can't talk about implementing that kind of evidence, because the policymakers, they have to know that it is going to really be cost-effective, as it's been shown to work before. So we ask the question: what is the evidence base for task shifting strategies for cardiovascular risk in low-income countries? So we did a study. I apologize for this slide, it's kind of dark, and we're trying to conform with NYU Langone Health slide package, but I'll read it for you. We did a systematic review, trying to figure out, if we review all of the evidence that we have that actually look at implementing cardiovascular risk disease, what do we know about this study? What we found was that when we evaluated the studies, and it's going to show up here, what we found was that there were probably 3-4 studies that are good enough to be included in this review. So this is a bit dated, but 2012, 2014, it's not a long time ago. But when you think about it, 2012, 2014, we did not find that many trials. What we found was that we found of the trials that met our eligibility criteria, only 3 of them actually were solid studies that we can look at. One was the WHO study, one was a study looking at diabetes and hypertension, and the third one, I think, came out of Pakistan that was looking to actually implement community-based strategies for lifestyle counseling. And in all of those studies, there was significant improvement in BP control. Problem with the study, despite that, was because they were not integrated within a given healthcare system. So we decided that what we would do is try to advance the knowledge in how do we integrate a task shifting strategy for hypertension control within the healthcare system in Ghana. So just to give you a flavor of Ghana, is in West Africa. It's bordered actually by Burkina Faso to the north, I believe Togo to the east, and Cote d'Ivoire to the west. Nigeria is somewhere here, after Togo, Benin, and then Nigeria. It's 22 million people, thereabouts, by the time we did the study. But I think the census, I think 27 million people. So anywhere from 20, I would say 25 million people to be on the average. That can fit in the whole of Lagos in Nigeria. So to give you some flavor of how small Ghana is compared to other countries. The hypertension burden in Ghana is about, we think, 3.5 out of 15.8 million people over the age of 15 as far as being hypertensive. In the Ashanti region where we did the study, with a little bit of enough thereabout here, is about 3.6 million people. So the Ghana health system, what does it look like? I think I have to give you some context so you can better appreciate the study we'll be talking about. So you can have what they call the community level care. So in, I believe it was 1998, Fred Gbenga, who used to be the Dean of the School of Public Health in Ghana, actually adopted something, he developed something called the Community Health Program Services. What Fred was thinking about doing when he developed that, funded by the Gates Foundation in part, was he wanted to show that if you go to any village in Ghana, you can have access to a community health compound. And the idea behind that was that you can rapidly deploy vaccination practices. If there's a case of an epidemic, you can have a systematic manner in which you want to really look at how you evaluate that kind of epidemic. So he developed the chips in the Kitambo area in Navrongo, which is much more in the north. And what he found with that was a very solid platform to actually implement primary care practices, was a solid platform to implement public health interventions like vaccination, was a solid platform to implement maternal child health practice as well. Because then what you can have is send what they call the midwives in the region to the chief's compounds to actually consult with women who otherwise would find it a long trek to get a community health center. So all over Ghana, within a mile radius, you have the chief's compound. And then you have what we call the sub-districts. And then what you have is the community health centers, okay? And beyond that, really, the community health center will provide care for a geographical area of 15,000 to 30,000 people. And it's really basic curative care, disease prevention services, and again, more sophisticated methods for maternity services as well. So that's the primary healthcare base of the system. And then you have the districts. And then what you have is the districts, or what they call the district hospitals. Now, you may call it a hospital there, but if you really look at what they call it here, it will be really a very, very nice and fancy community health center that has resources for some specialists. Not all the specialists actually will come every day, it will be probably once a week that you get to see them. And then you have the regional sector. And the regional sector is what they call the regional district hospitals. They are far more advanced. You have the specialists at any given time, but again, it depends on what you're looking for. And then you have the tertiary one. The tertiary care, Ghana has only 4, I believe. There's Kolebu Teaching Hospital in Accra. There's the KNUST Teaching Hospital. There's one in the Cape Coast, and I don't know where the 4th one is, but it's really 4 for the entire country. Nigeria alone, in Lagos, we have 5 teaching hospitals in Lagos alone. So just to provide some flavor as to how really spread out this is. So what we decided to do was say, given that this was implemented in, I think, 1998, and then in 2004, Ghana implemented the National Health Insurance Scheme, we decided that what if we take these 2 developments, what if we overlay on top of that a task shifting strategy to look at how we can manage hypertension within the entire region. So our proposal actually was called TASH, that's the Task Shifting Strategy for Hypertension Control. And the strategy behind that was really to look at ways to take the WHO CBD risk package that I talked about and train nurses within the Ghana Health Services at the primary care center level, okay, not the CHIPS compounds, because for that to happen, you need to have really highly functioning nurses in those settings. What if we implement this program within the Ashanti region in all of their community health centers? One, does it work? If it works, is it sustainable? Those are the 2 questions we asked in the study. So we evaluated, though, one other thing to say here. Because it was just unethical to provide the usual care in managing hypertension, we decided we're going to take a comparative effectiveness research approach. In other words, we're going to be comparing 2 active interventions. One is to provide health insurance because Ghana pays for it anyways already, right? The second one is, should we add tax shifting to the health insurance position? The health insurance in Ghana pays for primary care, it pays for medication, and it pays for visits. We did something very unique. For the health insurance, we wanted to make sure that the patients are not just plugged in, but they're also seeing nurses every time. So we bring them in, they will see the nurse every 3 months for a period of 1 year. So our strategy was to compare these two systems level approaches for hypertension control. One was to look at the WHO package, the other one was to look at that plus health insurance coverage. And our outcome was to look at systolic blood pressure. That's the top number of the blood pressure that we measure. And so that was the study. And what does the design look like? This slide is a bit small. We have 32 sites in all of the Ashanti region. It turns out that the director of the region was my classmate in med school, which was many, many moons ago. So he was very good in helping us to bring things together. I'll talk about that and why that's important in later slides. So we flip the coin and we randomize the sites, I think 16 each in each intervention, to figure out really how to make sure that we have a balanced population. And what you just see here is the study design. But let me explain to you briefly what the intervention entails. Basically, if your clinical site is randomized to receiving health insurance, we will give everybody that fits the study a health insurance card. We budgeted $200 per year for that. It turns out that was a lot of money. It was actually much cheaper than that. In 2012, I believe, there was a lot about the election. So the politicians were touting the health insurance scheme as something they want to give to the entire community. So we kind of just rode on the bandwagon of that to say, okay, if this is going to be behavioral activation of the entire population, can we make this much more popular in the region? So we'll give you a card, which means with that card, you have access to the clinic. You must see the nurse at least 4 times. Whatever the nurse does with your blood pressure is going to be dependent on what you do in that clinic. That's it. That's the health insurance intervention. For the second group, you also get a card. But in addition to the card, at that community health center, we will train the nurse on how to assess people's risk for cardiovascular disease. We'll train the nurse on lifestyle counseling. We'll provide prescriptions for the nurse to actually give the medications. Now, within the Ghana Health Services, there was no policy to allow non-physicians to actually prescribe cardiovascular disease medication. So what we did was we wrote a bunch of prescriptions using the current WHO algorithm, and then we trained the nurse on which one to give to the patient when they show up. And in addition to that, the nurses also have to monitor the patient every month instead of every 4 months. So for the health insurance scheme alone, they come back every 4 months. For this group, they come back every month until their blood pressure is controlled. Remember, the idea was to just use the WHO strategy. And then we measure, of course, their blood pressure, their weight, their height, we took their blood at the beginning in 6 months and then 12 months. At the end of 12 months, we terminated the study. And then we monitor them for another year to see whatever we did, was that sustainable or not? Did the effect go away? So in order to do this, though, let me see the results. Okay, well, I'll come to the results. In order to do all of these, it was crucial that we engage policymakers, because a key aspect of implementation science is to actually make sure that we engage policymakers to be able to appreciate how can they give us the buy-in to the system. Now, we were lucky because the regional director of the Ashanti area, Metro Health, was somebody we know very well. So he had already given us some form of buy-in. He made the nurses available, he provided the space for the training, and he actually started to implement some of the policy changes at the local level. So this includes Ministry of Health, Ghana Health Services, National Health Insurance Scheme. We had a one-day stakeholder workshop, but all of this we did, frankly, not at the beginning. That was the lesson we learned. We went in there with a pure scientific question. It turns out that wasn't going to serve us well. It was midstream that we went back to start talking to these folks. What did we find? The paper just got accepted in PLOS Medicine last week. We're doing some editorial changes. I can't show you the paper because I have to wait for the editors to give me permission to do that. Basically, at the end of 12 months, what did we find? There was a 20 millimeter of mercury drop in blood pressure. I'll explain that in a second. For the top number, for the intervention group. For those who received health insurance alone, there was a 16 millimeter drop of mercury. And this was sustained at 24 months. The difference between both of them was about 4 millimeters of mercury. So when you think about it, what that really means is that if we sustain this, okay, across the entire population, we can reduce heart failure by 50%, we can reduce stroke by about 40%, and we can reduce heart attacks by about 30%. What is really trending in Sub-Saharan Africa right now is not so much heart failure. I think that's been there for a while because of rheumatism. Everybody knows that very well. The key issue we have now is chronic kidney disease. Dialysis units are springing up everywhere. The second thing is stroke. There was an NPR, I believe, podcast that happened, I believe, about 3-4 months ago, that really shed light on the issue of stroke in Sub-Saharan Africa. Some people believe that the prevalence is as high as 25%. But what's really sad about the stroke is not so much that people have stroke, is that we're seeing this in younger people. So the age typically is about 50, 60, sometimes in the 70s in the old days. Now we're seeing them in the 40s. And a 40-year-old African with stroke, you can imagine, if that's the only breadwinner in the family, the cascade down in terms of the STS becomes a problem. So we found a working effect. Now, I have to say here, these are newly diagnosed hypertensives. Most of the drug trials that we do, we don't see this kind of effect. They're anywhere between 10 to 12 millimeters of mercury. However, in those drug trials, those are studies where we have patients who are not naive, which means they've already been treated and they know they're hypertensive. So here's what the graphic looks like. The red bar is the intervention plus health insurance, and the blue bar is just health insurance alone. Regardless, everybody did well. We had this 6 months because it was important because it's a concept we call regression to mean. The idea being, honestly, if I just take your blood pressure alone and you come back a week from now, and because I'm still the one taking it, it's going to drop. That's just the fact of life. However, it continues to drop right beyond that. And then it stays like that for 24 months. That's how we know that what we're finding is not an artifact of measurement alone. So what did we learn, and what are some of the facilitating factors and challenges that we encountered? The challenges was medication procurement. So if you think about it, a lot of the medications that were being used in Ghana, actually, only few of them are guideline concordant. So we have a drug called Aldomet for the docs in the audience. Aldomet is a very old drug, and it's been around forever. And it's actually a very effective drug, but the problem is, when you stop taking that medication, you have a lot of rebound. In other words, your BP can actually go back up again. The only place where we use Aldomet today really is in pregnancy, because pregnant women, because of the effect of medications on the baby, we tend to use only medications that we think will not affect the growth of the child. So Aldomet is very effective in pregnant women. Sub-Saharan Africa, though, in Nigeria, in Ghana, in Tanzania, is a very common drug. But the guidelines today do not recommend the use of Aldomet as a regular first line for high blood pressure. So that was the common one that they had. Now we had diuretics. Those are water pills. They had a lot of those. The other problem with that is that even with the medication, there's no constant supply. There are different types of medications. There are fake medications. And because we're doing a trial, we want to be sure that really we're giving the right medications to people at the right doses with the right algorithm. So we have to purchase the 4 classes of drugs that we use for the study. So that in itself makes the study somewhat artificial. Even though we're integrating this within the community, within the Ghana Health Services, the medication procurement was by no means and easy thing for us to achieve. So we bought a lot of drugs. At one point, we were carrying suitcases with drugs, and we dropped them at the centers, and we trained them on how to use them. There was a lack of leadership awareness. I just talked about that. For you to do such a study and implement such an evidence, the entire system has to be activated. That was something we did not do well, because we had felt that because CHIPS was implemented in 1996, thereabout 1998, health insurance was implemented in 2002, so we felt by 2012, there's some level of robustness in how these systems are in place already. That did not turn out to be the case. We were just extremely fortunate that the rector of the Metro Health in the region actually had a buy-in for the program. And the last thing was the lack of policy on drug prescription by the nurses. So nurses could not prescribe. So like I said, we had to have prescriptions in place for them, and we had to give them the medication. Now the facilitators though was that the nurses were very empowered. They felt for the very first time they could do something that's actually independent of what they would ordinarily do with the support of a clinician. The education and awareness aspect of the program was very important to them. The doctors, some of them in practice were very happy because you reduce the workload for them. I don't know if any of you have had a chance to look at how clinics are run in some of these health centers. I remember I'm from Nigeria originally, and we'll sit to see patients, and you have a long line. In fact, I used to come in and I have palpitations. There are 300 people waiting in the waiting room. But by 3 p.m., believe it or not, everybody's gone. So it's almost like a meal where you just run, you rush people through. What we did with the study was that we're saying that the doctors don't have to see the patient. Given the prevalence of hypertension, which is very high, the nurses were taking the load of the doctors. So that is partnership in PJ. So they really like that. And the nurses developed professionally, and health centers were able to provide better care. So the key thing that came up was that the nurses really learned this a lot. So, well, we did the study, we finished it. I've talked about the lessons learned. The key thing, though, is that despite what we found now, we've now shown that it can be integrated to the healthcare system. The next question when it comes to implementation of science is how do we scale up? How do we scale this thing up? What is it that we have to do to make sure that other centers can benefit from this? What we decided was to say a lot of things. At the community health centers, the practice capacity was just not there. Not every site had regular laboratory available. We had to do something called the point of care testing. We had to identify tests of all of these tests and do them there. So we knew that if we're going to scale this up, we really can't scale this up across all the healthcare centers without making sure we have some of those infrastructure in place. The second thing that we found out was that even if we have to scale it up, we've got to make sure that all of the health centers actually have adequate number of nurses in them. It turns out that healthcare in Ghana, all politics are local, is largely driven by the executive director from the district. So Ghana Health Services will pay, right? But you've got to make sure that in rural settings you have the nurses. We just didn't have that. Our study occurred, I didn't show you the map, in both rural, in semi-urban, and in the urban setting. And the place where we had the most impact in our study, guess where it was? It was in the rural. Because all of a sudden they were having nurses drafted to see patients in those settings. And that made a lot of sense. So we decided that instead of scaling this up to the healthcare center, we're going to scale this up, actually down to the community health compounds. Those CHIPS compounds that I talked about, I'm going to quickly skip back to show you guys that. Now we're going to come down here. The CHIPS compounds, we feel, have 2-year trained community health nurses. What if we go to the CHIPS compounds and we train those nurses how to screen for hypertension, which wasn't happening there, right? How to identify who is hypertensive and how to refer those people up to the health center. So that's what we tried to do in our study. And the goal of that, which is what I'm going to talk about, is to actually use 2 implementation science frameworks. One is called SEPHA, I will dwell on them. The other one is called REIN. Use that as a framework to develop what we call a hybrid clinical effectiveness design to evaluate the role of practice facilitation. So practice facilitation is really a very fancy term for a coach. So the idea really behind that is the provision of external expertise on practice redesign and a tailored approach to implementing guideline concordant care. And the strategy actually that we proposed was going to include an advisory board that will provide leadership and support the implementation of TASH in this setting. And then we're going to train people that we call the outreach facilitators. Notice that took part in our study. We're going to train them to then become the trainers, right, of those at the chief's compound. So what is the aim of this next study? Identify practice capacity at all of these sites. We want to know, do they even have blood pressure cuffs in these sites? How often do they measure blood pressure? And if they measure them, what do they send them to? Get a sense of what is happening at these sites. And then design a trial that allows us to do practice facilitation across all of the studies, but do it in a stepwise manner. In other words, we start in one place, we observe in another place, and then we roll out the sites in terms of who is going to get advantage to the study. And then want to compare our intervention, obviously, to how well people actually adopt the practices that we're trying to do. I'm going to keep this slide and come here to give you a better sense of how this actually works. So when you think about implementation science, you often have to think about what are you trying to implement? Is it evidence-based? I've showed the evidence of what we want to implement. The second thing then becomes, what outcomes are you looking at? The outcomes we're looking at in this case is not really the blood pressure reduction. We already know that BP will come down. It's a question of, can people actually adopt this strategy at those times? And if they adopt them, can they maintain that? Is it sustainable? And if it's sustainable, the first question then becomes, how do you then make sure that you can adapt that within the healthcare system? Those are the outcomes that we're looking at. But to get at those outcomes, it becomes important for us to understand what is the capacity at those sites. 2, how do we then engage our practice facilitation? And then 3, how do we use that to intervene? For us to get all of these answers, we employ something called the Consolidated Framework for Implementation Research. The idea being, that framework allows us to understand really the implementation climate, what they call the inner setting. What is the culture of care? What is the leadership support, if there is any? And frankly, what do the providers believe? What about the docs? How do they even look at this fact sheet? Do they even believe in it? Because if they don't believe in it, we're going to have to solve that problem first before trying to develop a strategy. And whatever information we come up with is what then is going to form the basis for the practice facilitation. So here's what the framework looks like. Very interesting framework by Inola Proctor from actually WashU in St. Louis. The idea really is that you have to plan. There's nothing new here. This is just basic engineering, even though we like to call it science in our field. There's something that's been used over and over again by engineers. So you have to plan what you want to do. Engage the actors that you think are important. Refine what you want to do, and then execute. But while executing, you've got to reflect and evaluate what you're doing. Those are the 4 constructs that you're looking for. To plan, though, you have to think about who the actors are. So in this case, the actors are the patients, the providers, who will be the community health nurses, the doctors, the clinicians that they have, and who else? Who is paying for this? The health insurance plan, right? And then, of course, who is paying for the staff? The Ghana Health Services. So what we're beginning to do now, we just came back from Accra, actually, was we engaged the community health workers, I mean, the Ghana Health Services, to tell them, here's what we want to do. What do you think is possible at the chief's compounds? And we're asking them to give us a sense for how they think they want to manage hypertension at those levels. And we're using that now to also do something called the practice capacity survey. We're surveying about 300 chief's compounds in Ghana, in the region we're looking at the Kitampo-Kumasi region, and to understand, do they have blood pressure cuffs? How do they procure medications? How do they refer patients up the ladder? And who pays for the care that people receive? And frankly, how often do people use the healthcare services? Because we found in our first study that a lot of the rural areas, they were mostly farmers. Farmers really don't, they don't use the healthcare setting very well. They're very hardy. They didn't think they have to do that. And so, but the moment they got health insurance, they all actually ran down to the healthcare setting. So how often, what is the healthcare seeking behavior? And then who are the providers here? So we're collecting that information to help us design this study. The second framework that we're using is actually REAIM. And REAIM really stands for is reach, effectiveness, adoption, implementation, and maintenance. And the idea is that these are the outcomes we're looking at. Our outcome is not a clinical outcome. That's why we call it a hybrid intervention. Our primary outcome is to understand, does practice facilitation at the CHIPS compound, does it lead to the adoption, does it lead to the reach, the maintenance, and the implementation of our cash strategy? That's our primary question. Our secondary question is, if it does that, by the way, is there a concurrent reduction in blood pressure levels in the people that were referring to these practices? And here's how you define a lot of these outcomes. They're kind of not as straightforward as you would for a clinical study. But here's what adoption means. How do I develop organizational support to deliver my intervention? Well, we're doing the stakeholder meeting to help us achieve that. Implementation. How do I ensure that the intervention is delivered properly? That's where training comes in. We plan to train a lot of the nurses that have been trained before, to train other nurses, so it will be sustainable. Maintenance. How do I incorporate the intervention so it is delivered over a long time? So we have a 5-year study where there will be training happening every year for the 5 years for different levels of nurses. And what is our reach? In other words, how do I reach the targeted population? The population we're looking for here will be rural people, right, who tend to use the CHIPS compound. And then, of course, is it really effective in improving health? And that's our secondary outcome there. So if you've done that, I thought I cannot give a talk on implementation science without talking about scale-up. And I figured that what you see here is, let me see, this one right here. What you see on this slide here is really a good way to think about if we are successful tuning 4 years from now to the 5-year study, when 4 years' time, we have a sense of where we are. If we are successful, then the question becomes, how do we then make this a national pastime for Ghana or other places? To do that, though, here are the different stages that you have to think about. There are phases we call them. We know a best practice exists. We know we have a good idea to scale up. But we've got to set it up. That's the phase where we are right now. We're going to all the CHIPS compounds, we're doing practice survey, we're meeting with the leaders in the field, we're trying to understand what do they do and what they do. Once we've done that, we have to have a scalable unit. The unit we're trying to scale here is very straightforward. Can we train community health nurses to screen people for hypertension and refer them? Remember, the awareness rate of hypertension, at least in Ghana, is less than 4%. 4%. In the US, we whine a lot about our hypertension awareness. I'm on that task force. 85%. I mean, we still want more awareness. If you're not aware of it, you won't know that you have it. You won't know where to seek treatment or not. So our scalable unit is to increase the awareness for hypertension and to increase the referral of hypertension. Once you've done that, then you've got to test that scale up. That's what we're doing right now. We're testing it using a step-wise design. And if we're successful, 4 years from now, we can go to full scale. For any of this to happen, though, here are the mechanisms that have to happen. Leadership has to be involved. Of course, we're talking to Ghana Health Services. We didn't do that in our first study, as we could have, right? Communication is important. We're going to have major behavioral activation. We're doing campaigns in most of the villages, so people know that if we're in town, this is happening. Otherwise, then you don't have a tipping point that can then help spread this across the area. There have to be social networks. That would be a bit challenging, but we're thinking that if we build a social network of the providers, they can talk to themselves in a regular meeting. If we build a social network, actually, of the patients as well, or the community, we can do that. If we do a social network of even the leadership, that may help us to see where competition can actually foster a scale-up easily. And of course, there has to be a culture of urgency and persistence. We don't have that. But with the advent of a lot of stroke, with the advent of dialysis in most places in Ghana today, we're thinking that we can engage the community to start talking a lot about that. We did one of those workshops just 2 months ago, actually. And then finally, you need support systems. So there has to be learning systems. We have to create a place where people can actually get the training, not just for the study, but concurrently as is required. We need data systems that we can do. We need the infrastructure to scale up. We need the human capacity. It turns out they have a lot of community health nurses. The problem is they're not doing much other than giving vaccinations, right, and following up on children who have diarrhea, which is a big deal, but not that much. And then capability and sustainability. I think I have to leave some time for questions, and I've been instructed to actually say, could I announce that the viewers that they can type their questions, and you can use the chat options as well. And please, you can hover around the green bar on top of the screen to use the chat option. I'm not seeing the chat, but our folks here will let us know if that is what your questions are. With that, I have to thank and acknowledge our collaborators. Professor Planjul is the director of the Ghana College of Physicians and Surgeons. Is the PI with us on this study. He's for the KNUST. These are our research staff for the study as well. And of course, we have the Ghana Health Services. The director of the research center, Ben Kitampo, is also on this study with us. And I have to acknowledge Heart, Lung, and Blood Institute. They funded the study. And the Global Alliance for Chronic Disease. With that, I think I'm going to leave a lot of time for questions. Again, for the viewers, please type your questions using the chat option. And you can hover around the green chat and send your questions in. Thank you for your attention.
So, thank you for your sharing your work with us. While everyone is still thinking about all their questions, I'll just start off with 1 or 2 questions before we open it up to everyone online and everyone here in the room. So for people who are listening and for us here, we just want to know, how did you get into this field of, we know that you do a lot of hypertension research, but how did you get into the implementation science part of it? How did you transition your work into that area?
I was looking for money. I think my primary work actually is on reducing the cardiovascular burden of hypertension in blacks in the US. That's my day job. But about 9 years ago, I was fortunate to go to Ghana with Bob Byrne. So Bob was the VP for health previously. I think he retired about a year and a half ago. So I was in Ghana with Bob and a whole host of other NYU faculty who were exploring collaboration. Because we have NYU Accra, we have the site there. And when I was there, being from Nigeria also, that was my first time in Ghana, I was excited. It's amazing how if you take yourself out of something and then you go back, you see something different. The first thing that occurred to me was that at the time, the teaching hospital just actually funded a cardiovascular renal unit. And we're very proud of that unit. But I was seeing something different. To me, I was seeing a lot of what you might call it, dialysis patients. So I started thinking to myself, what can we do with hypertension? Is it really a problem here? So that got me thinking about the epidemiology. And a year after that, I was back there again. At my time, we only had a small MPH program, I believe, at Steinhardt. I went to about 8 students, and we spent about a month in Ghana, working with other Ghana colleagues in 2 of the slums in Ghana, Agbogloshi and Oshatown. And we saw a lot of hypertension. And that's when it became very clear that we've got to do something about it. So most of my work in the US is clinical effectiveness trials. So doing trials is not foreign to me. But taking trials and looking at the evidence of what was and implementing it, that became a new thing for me. So about the same time, serendipity is very important in academic career. The Global Alliance for Chronic Disease invested about, I think, $20–30 million with other funding agencies to look at hypertension. And I'm like, okay, if it's hypertension, we can do this. And so that's where this came up. That's why I got the interest. So it's been for the past 7 years now that I've been focusing on this work. Of course, since then, that's all I do now.
Any questions?
Yeah, so fascinating. The past research clearly showed that you have the same efficacy with the task shifting as with the classical system, and pretty high efficacy is 20% in it. But then does your new design have the next three obvious questions? The one that Jason was going to ask, the cost.
Yeah.
What is the cost difference between the two strategies in the future, and then changes in effective coverage actually of the population, and ultimately changes in prevalence of hypertension. That's part of your next design as well.
So what we did was, I did not show that today. I shared that paper with Yashin. We actually ran a cost segment analysis of the two strategies already. We're going to submit that separate paper. We have to get the first, and then we can focus on it. And the preliminary data we're seeing is that on the short term, there was no big deal. Remember, these are two active interventions, right? So if you add the task shifting strategy to health insurance plan, you didn't get that much of a dent in the first time. If you keep all those conditions constant and look 10 years out, I think they were saying somewhere about between $5 to $10 billion that could be saved if we implement task shifting strategy across the entire system. Now, that is preliminary. We have to go back and look at that data again. Most of the problem we had in putting that together was because we have to get a lot of cost data from National Health Insurance Plan. It turns out one of our graduate students, Kofi Kwache, in this program actually, I tasked him with getting that information because his thesis is actually looking at the effectiveness of the NHIS with respect to IUD for service or IUD capitation. So he had access to some of that data. So we took that data along with colleagues at the med schools called Braithwaite, and we think preliminarily we can save about $5 to $10 billion. But we're going to have to write that off now. Now that we have the primary paper, we're going to have to look at that information. That's a good question.
But that seems like from the health system's point of view, and you pointed out that there are, a large portion of these costs also all of the households and patients.
Yes.
So there's the out-of-pocket
dimension
to it, which also should be equally investigated.
Totally. I totally agree with that. I think the problem we have, so there's another EU call that just came out to look at scaling up interventions in sub-Saharan Africa. So we're in Tanzania with Karen Yates, and we're talking to the government there to see what if we take PASH and scale it up in a particular region. It turns out that the problem they have, they actually have this very fancy health insurance scheme called Improved Community Health Fund, ICHF, with the folks from Netherlands, the farm access with the group. Incredible stuff where the Dutch government is investing in the Tanzanian government health scheme to help them think about redesigning the program in such a way that when you go to the rural and the semi-urban areas, people are not paying too much money out of pocket. The challenge, it turns out, is the health-seeking behavior is so bad that people aren't used to health in a way that I want to prevent health. How do I say this? I want to prevent catastrophic health conditions. It's not a mindset. So even when farm access provided ICHF to folks, they enroll, but they only stay for a year. After a year, they drop out again. They're not interested. So we're struggling with how do you, so the data is not a lot, other than when they are.
One of the contentious issues is I think when you remove user fees because they just lost it, there's going to be the utilization is going to and then they're not going to be able to keep up with it, but that seems like it's not really the case. You still have to work on the demand side.
Totally.
Okay, we do have one question from an online attendee. Chris Dickey would like to know, would there be opportunities for global health students, especially here at GPH, for the ramp up or the scale up that you talked about?
Okay, let me see. I'll answer this out properly. I think yes. Right now I have information science lab that has, I don't know, I think about 5, 6 CGPH students in it. Some have gone to Tanzania already as part of planning for the Tanzania grant. I think Chisan was in Tanzania. I think, you know, Julie is on the program as well. You are. And the opportunity, I've not publicized this enough because I want to make sure I get my act together first. And let me tell you what I mean by that. For you to provide opportunities for students, there has to be a solid infrastructure on how to do that. And what I'm trying to do with this first round is, because we have the grant now, we've got to think about, you know, what are the potential cities that people can write? And are people really willing to travel to Ghana? And what would that structure look like? How much class would you need? Can that be part of a capstone? Those are the things I think we can leverage it certainly, but we have to be very specific on how we do it. For now, I've just been taking people who are highly driven, that can do stuff on their own, but also make it available as I think we'll think more. But it's a 5-year study, and we're writing 3 other grants using the same model. So I think in the next year we should have a much better way to integrate more students than we currently have.
I wanted to, this is really exciting work and the work you're doing with prevention. I wanted to maybe ask you to push the boundaries out a little bit and provide some reflections of the bigger context of the communities in which people live. You mentioned end-stage renal disease, and presumably that's related to diabetes as well as hypertension and that the food system. And what's the Ghana Health Service is pretty sophisticated and has been around for a while. Are they thinking in broader public health terms around prevention at a community level, dealing with the changing conditions in communities, dealing with diet and other exercise, other kinds of issues, which may be more of a problem in the urban areas than the rural areas? But I'd just be interested to see how does that appear in your conversations with them?
With them, we haven't gotten that far, but what we've talked about is primarily to figure out a way to use the CHIPS compounds as a way to address non-health issues as well, because people have competing priorities. The pushback we're getting, and my guess, I mean, you probably know this one too, is that a lot of the healthcare systems in the region largely depend on donors. And the philosophy, for me at least, is that the hand that gives dictates. So every time I talk to Gbenga, it would be, okay, we got money from Farm Access, let's say, but WHO, they won't let us spend that money on anything else other than what it was supposed to be spent on. And I think that's where the problem comes in, right? For the Tanzania work, though, what we do is we actually are trying to build in a community health worker model, where the community health worker is not just helping you with your health issues, but helping you to set goals for other competing priorities. Now, does that mean you can talk about the issues of food access and all that? I don't know that it does. And this is where the SDGs come in. But I just don't think that, if I have to bet, I don't think that we're going to see programs that we think in such an holistic manner. Because there's still not a good structure for how you provide healthcare in the region. But what I've heard from them is that the donors don't allow them to use the money in flexible ways. Global health is really important. I totally agree with you, because there was a patient that came to give a talk. We're in Ghana. We ran a CKD, chronic kidney disease workshop, where we brought in a patient who was on dialysis. And when you listen to him, he wasn't talking about his health. He was talking about the other things in his life. And that was like the way what led him to have kidney failure. And it's amazing how we focus on that one thing, but we're not thinking of these other factors, social determinants, as some people would call them.
It's true everywhere.
Totally.
Is it part of the solution? I mean, this is classic, the donor driven project, vis-a-vis the rest. But one of the solutions that the bank has been working on now for 15 years or something like that, is influencing medium-term expenditure frameworks. Ghana has this pretty substantial national budget, and therefore making sure that these longer-term priorities population policies that are much wider are then covered in the medium-term expenditure framework and are covered to the largest extent possible by the domestic resources. It's a highly cost-effective intervention. But that's where my earlier question came in. That's where the cost-effectiveness is going to come in, because what Ministry of Finance wants to know is, what do I buy for my money? So if you come with solid, your study presented as a cost-effectiveness study, the first one who will buy it is the Minister of Finance. Put it into the framework, so and let the donors fund HIV/AIDS, fund vaccinations, fund malaria, but then have the national budget go towards the, let's say, the higher priorities, the population policies, and the longer term. Ghana would seem, from our experience, would seem the type of place open to this level of sophistication.
No, because I want to be careful what I say. I don't have that much hope, because my belief is that if sub-Saharan African governments want to have any dent, let's forget hypertension on anything, they have to drive the policies themselves. If you look in the past 10, 15 years, the only thing in my mind that has really been very effectively, maybe that's a very strong word, managed with some results, is the PEPFAR fund for HIV. So we staved up the epidemic. But that was a ton of money in a very short time, right? And so, and that's where trickle-down economics really works well. NGOs everywhere doing HIV. In Nigeria, there are 15 of them, right? Because the money was there. The problem is, a lot of the strategies that have been proposed are coming from the West or from the North. And so people, and then with the history of colonialism, you can strike this part. People just can't come up with their own solutions. And so when you say Ghana, Minister of Health, they're waiting to be told to adopt that. It's not coming from them still. We have a ton of experts. I don't know anywhere in the world where you have more experts than more population. It's in Africa. So it's a very, I don't know, I mean, you probably heard it already. Bloomberg just committed, I think, $250 or $215 million, $250 million to Tom Frieden, and it's called Resolve, I believe, to look at ways to address cardiovascular disease. And I look at what Tom put together, 4 or 5 things, and I'm like, this makes a lot of sense. But where is the government engagement in that? Right? Again, it's the donor coming down to say, we think this is what you have to do. I'm not saying what Tom and Bill are doing is wrong. It's good. It's important. We need that for NCDs. But I just don't know that if we don't have a bottom-up solution, bottom-up meaning from the African countries, rather than just the framework, it's going to work. Rwanda is beginning to do that a little bit, I think. But I think the best we can do is to showcase the evidence, that there's evidence in the region that these things can work. Now, where they take that, that's a whole different solution.
I would just, I think that's a really important thing to emphasize, because there is so little evidence base of the application of these interventions in the South, really, and in Africa, of course, in other regions, and we have a different racial population.
Right.
In the U.S., the clinical interventions are different.
Exactly.
And so really building up that evidence base is a really important set of arguments for both funding local researchers and local changing their policies.
I think so. I'll give an example. Out of WHO, they have, so this was the CBD, the WHO CBD package was expanded upon to create something called the Global Hearts, right? So I went to Geneva twice. It was exciting. My first time to work with them. I know Yeshimo worked with them a lot. I was like, why is this how this place looks? Really impressive place. So they brought people from different countries. All of the WHO regional officers were all there. And Ethiopia, Uganda, I believe Tanzania were there, and Zimbabwe were there as pilot sites. My job was to figure out with the Southern African contingent, how are you going to scale up this program or roll it out in the region? And when I went around and I asked them, each and every one of them, these are deputy ministers of health. You know what they said? You tell us. And I thought I was confused. I said, well, my job is to coordinate. So I have to report back to the group, like this is what we decided. They said, no, Gbenga, you tell us. I said, what? I said, I'm a consultant. I go, no, WHO, you work. I said, yeah, I consult for them. But in other words, the point I'm making is that they came to the meeting thinking that, or believing that they will be told what to do, and they then go back and do it. So that's where I think they disconnect. And that's why I started getting a little bit, so we went to Ghana Health Services. We actually asked them, before we wrote the second grant, can you guys tell us what is the best place to do this? We don't think we can scale up yet because the medication procurement and all that, we don't think we're ready. But can we do screening and referral? But I'm in Ghana 4 times a year for other reasons. So you get to keep banging on the door. The point I'm making is that it's just not, there has to be a way to change this mindset. The mindset is so important. There's a lot of money, $200 million, to scale up this. This thing costs us $450,000 a year for 3 years, and then $250 for 2 years. That is barely $2 million. It's not a lot to be in one region, right? And we bought the medications, we did the lab, and then we paid for our travel. So we can do so much more, right? We can reach so much more with little amount of money. But the political will is just not there because it's being driven by the donors. I think, not that donors are bad, I just think that it's just being driven from the north or the west. And so these folks don't have, that's another thing, to build capacity in that regard.
Are you sure it's the mindset or the empowerment?
Yes, it could be maybe empowerment.
It's a very interesting question because the president of the Uganda National Academy of Sciences, Mwakamba, has written a paper on changing the mindset, and Africans need to own their own development agenda, and his academy is working very, very hard
to do that.
I think it's both for sure, but all the donors have been signing documents for 20 years, and it has to be country-led. Taken.
Right.
Okay. But here again, Ministry of Finance, that distinction again, where health is squeezed is on two sides. Health is squeezed vis-a-vis the donors, and health is squeezed vis-a-vis finance. Vis-a-vis finance, they're taking very little serious, and so they are overly dependent on that. In finance, you often have some people with more, what you call the mindset, who insist more on their own budget decisions, at least in terms of the local revenue. So the key question then becomes, how did the economists in the Ministry of Finance get that mindset? And how can we get the health people get that same mindset? It's not a matter of color. It's a matter of situation. Let me put it that way. That's why I'm saying it's empowerment in the end.
Yeah, I think it's different. As a physician, I would say my job is to treat people, right? So you're trained to treat people. That's the same thing here. It's the same thing here.
Okay.
By the way, just so you know, we will just implement hypertension guidelines forever. And people say, look, listen, Gbenga, I'm busy. My job is to see the sick patient and treat them, right? Now, do we have a strong public health advocacy? I think that's the point that Joey was asking. If we don't have that, I think that's where that becomes. So I happen to double up on that too, right? But as nurses, as physicians, as healthcare workers, they want to take care of patients. So the Minister of Health, interestingly, in all those countries, look at who they are.
Of course.
It's the same, right? The same people. So it's
your classmates.
Now, the different classmates in Ghana, in Nigeria, I think I'm not quite there yet.
Thank you everyone for being here. We're going to have another one April 11th, so please come join and we'll see you again. And to our listeners out there, please join us again April 11th. Thank you very much.
Thank you. I just filled in for Victor Davila, so this was impromptu. I was drafted by Melina last night.